So thanks so much for coming on behalf of Capt. Obviously in this training space. Thanks for joining. Tonight we have Captain Steve Adelsberger. Captain Adelsberger is Shift Commander 1A, so significant leadership within the fire department. Steve has organized this session and has invited some amazing guests from the Baltimore County Department of Health to talk about the peer support network or services that we in Baltimore County are going to be tapping into with the Department of Health when the substance abuse and mental health comes. So thanks so much for the generosity. Steve, thanks so much for your time.
Yeah, you're welcome. Thank you for the introduction, Dr. Baron Holtz. We're very excited to be here. As we've started talking about the topic, the opioid crisis obviously is a huge national epidemic. Being on the front line, we certainly know what that means to our community. We all have had friends, family, peers that have been affected. So this is truly a community issue. And I know, speaking for someone who's been doing this for a few years, there's always been some disconnect as to where we were going. Senses of hopelessness. We use the term empathy fatigue, meaning we all came in this business because we care and like people. I think that's at the core of who we are. But when you go on these calls over and over and over again, and it doesn't seem like we're making any progress in either clinical outcomes or future rehabilitation of folks, I know folks in my position have just had concern about empathy fatigue. Are we as empathetic to the public as we need to be in trying to understand their crisis? When I first came on, Narcan was around. We'd save lives, use Narcan, wake people up, pat them on the back, understand it was a difficult medical problem they had, and just wish them luck. Program evolved to now we kind of forward deployed Narcan to law enforcement and to others in the community. They would administer the Narcan in crisis. Folks would wake up, they get another pat on the back. This is a tough one. Good luck. We hope it works out for you. And I know personally for me, there was times where I just felt like, are we making that difference? What difference did we really make? In February, we had a meeting with the health department, and we had a meeting last week, and a comment was made by one of the supervisory staff at the health department that what really struck us at this meeting was when we introduced this program, you all sat up in your seats. And I remember that moment at this meeting when they were talking about this new program that we're going to go over tonight, that this is the missing link. This is the thing that we've been missing in taking a clinical situation and having it go through the system where folks have a real chance to improve their lives. Again, when I first came into the department, we saw people with opioid addiction as junkies. They were on the lower end of the socioeconomic spectrum. They're not like us. And that was certainly a bit insensitive, but it, I think, was viewed as society as culturally not our problem. And like I said, as we see, there's no demographic. We've had kids die from overdosing on parents and grandparents' methadone in the county. We've had elderly residents of nursing homes overdose on opioids. We've had mothers overdose in parking lots with children in the back seat. So we know this problem is everywhere. And so the fact that there's no demographics, it kind of hits close to home. And it's really important that we not only can revive and resuscitate, but also put citizens in situations where they can hopefully see this problem through to where they rehabilitate and go back to having productive lives. Kind of historically, going back a little bit, kind of mention how people with opioid addictions were when we first started. Not us. These people aren't like us and things. And again, very, very unfair, very simplistic. It's hit home. now we have the linkage, I think, to get folks to where they need to be. The problem's pretty complex. I know pain, I went to a presentation today, Dr. Schutz from the Poison Control Center was talking about pain was seen maybe in the late 90s from the medical community as the fifth vital sign. It was a big customer satisfaction score in terms of how you were rated, and maybe even tied in with funding. So overprescription of pain medication just became part of the medical industry. Oxycodone kind of came on the scene. I think that was advertised as a non-addictive pain medication. We've seen that is false. So there's a lot of reasons why a lot of pain medication got into the communities. So people got hooked. Others who maybe had substance abuse issues had access. Everybody had them in their medicine cabinets, so people had access to them. I know my encounters when I talk to folks, I'll spend some time in the back of the ambulance, like, tell me about your journey a little bit, tell me your story. And they're all usually very compelling. And I don't recall anybody saying, I started out wanting to be an opioid addict. Many reasons why people get involved with things, but a lot of it was a little bit out of their control, and then they find themselves in this spiral that they can't get out of. With the pain medication piece, some folks, that have the chronic pain, will get addicted. Their body requires more. They can't get on day 16, their prescription's out, their physician won't write them more medicines. They're looking through their medicine cabinets, looking through our medicine cabinets. They'll buy medications off the street. It's about $1 per milligram, so they're paying between $50 and $80 a pill. That's unsustainable over time. The body's requiring more, and that's kind of where that $10 rock on the corner starts becoming a financial reality for them, because their body can't afford. And most people don't start with the needle that I talk to, and nobody picks up a needle and says, I think I'll inject this. They'll snort it, and then again the body keeps needing more, and then they have to go to that pathway, and we certainly see what that means. Fentanyl's changed the game, and why is that? It's like a lot of things in life, it's about money. A kilo of heroin is about that big and costs about $85,000, which means you have to harvest poppy in Afghanistan, you have to process it, you have to package it, you have to ship it, and then it has to be distributed. The same amount of fentanyl that provides the same amount of street value as a kilo of heroin is probably about that big, costs about $2,000. So it's much more profitable, which has kind of driven what we've seen, but obviously the danger, as we know, is it's much more powerful than heroin that's processed overseas. It was coming from China, basically, which created some distance and those things in terms of getting into the United States. Those scientists went to Mexico, and some of the cartels in Mexico developed labs where they were developing fentanyl there, which was a lot easier to get across our border. And from what I'm hearing from our Baltimore County law enforcement folks is the cartels in Mexico now have their own scientists that are making their own fentanyl at a much cheaper cost and able to get it across our border just a little bit easier. So when you kind of add all those things up, I think that kind of speaks to proliferation. But a lot of it is about the profit, I think, in the drug industry of why fentanyl has become so prevalent. It's a lot cheaper to produce and has a much larger profit margin. Obviously the danger is that these aren't scientific pharmaceutical doses. When they're mixing this with other substances, there's a lot of variation as to just how powerful it is. And that's why I think partly we're seeing folks using what may be their normal amount or what they normally use, but that particular strain is more powerful, and there may even be some mental process on those folks where if somebody's got a better product, they may even move towards purchasing from that within the industry. Again, at the present, we'd give folks Narcan. We'd restore their breathing, hopefully. We'd take them to the hospital. They'd be observed for a few hours. When it was safe for them to be discharged, they would leave. We hear from a lot of family members that they felt less than involved in the system. They're just over in the corner. Again, a little bit of that empathy fatigue. I don't think because anybody purposefully wanted it to be that way, but just as ED volumes, the pace of ED, the pace of us, we revive, we treat, and we have 10 more calls or 10 more patients we need to see. So there was a gap in the system there as well. Again, in February, we met with the health department and they told us about this new program, the Peer Recovery Support Services Program. And as they started talking, we started sitting very forward in our seats, very eager to hear about this. And this program allows us to link these peer recovery specialists in real time with citizens in need that can broker and provide some linkage into services that lead towards treatment and rehabilitation that we hope is successful. We have several folks with us tonight that have been very instrumental, and we're at that meeting, and I have Hillu Beyene. He's one of the peer recovery specialist supervisors, as well as Tiffinee Scott, I'm sorry, Tiffinee Scott. And they're the supervisors, and they're really, from our work with them, really have been the backbone of the program. We took that meeting, developed a relationship, and have had a lot of real incidents. They've come out, ridden with us. We've done some grassroots battalion level training as to what they can provide, and we've seen some miracles happen on the street. And I can't express enough support from my end as to where I think this program will take us. My career, I've seen many good things. I think this will be one of those benchmark moments where this linkage really will benefit the Baltimore County community. Hillu and Tiffinee will tell you what it's about, how it was designed, where it came from, their personal experiences, and then at the end we'll kind of come back and maybe look at some operational elements of how we've used their program on our incidents and on our scenes to affect positive results. So with that, I'll pass on to Hillu. Any questions so far?
Thank you, Capt.
Make sure the slide changer here works. Yeah.
Okay. All right. Thank you.
And then there's a slide changer here. I think forward
Great.
and back.
Thank you.
Thank you.
All right.
You have water, right?
Yes, I'm good. Good evening, everyone. I want to again thank the captain and all of you for letting us into your house, inviting us over. It's really an honor to be here, and we've been to some of the stations. My name is Hillu Beyene, and just to give you a little background, I'm a person in long-term recovery. When you see the word peer, you're peers to each other, and that's exactly what we are. We're peers to those that are suffering out there also, because I come from a personal experience. On my end of the story is I'm a person in long-term recovery. And what that means is that I haven't found it necessary to put any kind of mind or mood-altering substance into my body for a little over 8 years. After 36 years of addiction, jails, institutions, homelessness, and all those things. So as a result, my life has changed way beyond anything imaginable. I've become a better son, a better father, a better brother, a better contributing and part of my community and society as a whole. Being able to do that has been a real gift. And what we do is we try to really put a face of recovery. When I was hopeless, I could never imagine me like this. So we try to put and lift that stigma up. So as a result, now I work for Baltimore County Health Department, Bureau of Behavioral Health, as a behavioral health associate, peer recovery support specialist program supervisor, along with Ms. Tiffinee Scott. And so I'm going to go through some of how it came about with the county, and if we'll talk more about it. So we're just going to go through, I'll get it started, and then Tiffinee will come through after that. Just to give you, the Baltimore County, our overview and our vision is, the vision of the Baltimore County Department of Health is to have healthy people living, working, and playing in Baltimore County. Our mission is to promote health and prevent diseases through education, advocacy, linkage to resources and treatment by improving the quality of life with the implementation of peer support services for Baltimore County residents. One of the biggest things about how we grew and how it became able to do the work we do is our organization leadership buy-in. That is so important. At the health department, the buy-in we had, the leadership of Baltimore County Health Department, when they started dibbling and dabbling about what is this peer service, what is peer recovery support specialist, they came to say, wait a minute, there is something of value about these peer recovery support specialists, because now not only do we have our personal lived experience, we've been trained professionally, now have become certified by the state of Maryland with the same board that certifies counselors, therapists and such. So we came along with that. They said there is something about this. Then they went a little further and they were just ready to jump in, something they're not quite sure. As the captain has said, you know, they started listening and jumping in. It's like it's unexplored, but let's try it. Let's try something different to enhance what we've been doing and to identify the critical needs. These are with people with some lived experience, either through family association and such, so let's give it a try. And then that encouraged them to go try to find the resources and funding available to have these peers in there. So once we had that buy-in, they were ready to jump in and provide whatever support they needed to. So just to give you a little idea of how the expansion happened so fast, is in 2016, there were only 4 of us, there were only 4 peers in Baltimore County Health Department. 3 of them were in the outreach, meaning go out and do outreach work or go out and talk to people and such. We had 1 in the detention center, which connected peers there at the detention center before they got out, got them ready to transition them into supportive housing and help them in their recovery. In 2017, the detention center from 1 went to 6. We added 5 more recovery support specialists. 5 of them identifying especially mental health challenges. We added also another primary focus on mental health, and we have 6 in the detention total. And then we added 1 in co-occurring, and 1 we added in Department of Social Services. The 1 in the Department of Social Services was particularly working with addicted mothers, pregnant, postpartum, and babies. I'm sure you've run into a lot, you know. So that's what she does. She strictly takes care of those moms. Well, in 2018, it jumped. At that time, we said, wait a minute. They found the resources. They said, we need more. We need more of this to support what we're doing. At that point, we hired 2 more, 2 in harm reduction. And we'll talk about that because we meet people where they are. One of the things about peers is that we don't wait for you to be at a certain point. I came through a total abstinence program, but guess what? I meet them where they are. We're open to many pathways. Everybody's recovery looks different. We'll meet them where they are, when they want, when they need it. So we have 2 in harm reduction. Then we added 13 more at one time outreach workers. 1 peer supervisor, Tiffinee Scott was added on. Then we have 2 peers at the emergency department at St. Joe's Hospital embedded in there from Baltimore County Health Department. We have now we got started engaging with you guys. We've been on ride-alongs and done some outreach work through that. Reach outreach team 4, and then 1 in the families. The reach outreach team, which we'll talk about a little bit later. So that's what we have. So total, we have 26 peers in just a matter of few years. And then we're also in line, we just added 1 more peer in the detention system to service substance use disorder. So in all, we've got that covered. So as we go along, I'm going to let Tiffinee go on and take you through some of that, and we'll talk about the reach line. Thank you, everybody.
Okay. So good evening, everyone. Thank you for having me. I'm Tiffinee Scott, and as Hillu mentioned, we are peers that are in recovery. I'm For myself, I'm in recovery from my family's co-occurring illness. So I subsequently lost my dad for alcoholism, and my mother is in recovery as of today. So just speaking about some of the requirements to engage in peer services, you had to be a Baltimore County resident. However, if you call that line, anyone that calls in on the 41088 reach line, which I'll discuss a little bit later, will hand them off to any prospective county or Baltimore City. You have to be an individual with substance use, mental health, and a co-occurring disorder, a desire and a willingness to change, and willing to engage in peer support services. So what services are offered in Baltimore County from the peer support team? We have the 41088 reach line, which operates Monday through Saturday from 8:30 a.m. until midnight. What's unique about that line is a person with lived experience will answer that line, Monday through Saturday, 8:30 a.m. until midnight. We also offer one-on-one peer services, linkage to detox, linkage to treatment, mental health services, linkages to connective services, assistance with supportive housing, assistance with any immediate needs for individuals and families, transportation by county vehicles. We have 5 vehicles that we provide transportation for anyone seeking recovery. We also transport by cab. We offer navigation to Maryland Recovery Net funding, and that's additional funding offered by the state for individuals seeking housing, supportive housing after they leave treatment. We also offer one-on-one naloxone trainings, support groups at our Drum Castle office. We offer smart recovery meetings. We also do other recovery services oriented meetings as needed. But what's really unique about the smart recovery meetings is they are offered not only for individuals but also for their family members. We do street outreach, which you've seen Hillu dressed in his green t-shirt. So if you see anyone in the community wearing that t-shirt, big and bright green, we are there to provide peer recovery support services. We also have peers that actually go into the court system and support individuals in their criminal justice process. We also have the family peer, which Hillu mentioned earlier. We also offer mental health first aid trainings, which is our first one is actually next week. And we also do peer recovery coach trainings. So their peers are utilized everywhere within the county. We're stationed in Drum Castle. We are in recovery and wellness centers, in the hospital emergency rooms, as Hillu mentioned. We're in DSS, the detention center, which now has 7. The Baltimore County courts, along with the fire department, we are collaborating with them well. The police department, where we we respond to overdose reports for multiple incidents of overdoses. We do community outreach, street outreach engagement, the Anti-Stigma Project, which talks about the stigma of medicated assisted treatment. We do community events everywhere within the county, and also we do some school outreach events and any other locations by referral. So this is one of our very first responses with EMS when one of us actually rode along, and that's for a person was engaged in services and was connected to treatment. This is what you see pictured in this slide above us is Hillu actually doing a street engagement with a person on the side of the road providing naloxone trainings. We have this the detention center, and it's a very unique process within the detention center because it's 3 different units, as Hillu mentioned, but we also just added that substance use peer that will engage anyone and also offer peer engagement at the door and upon exit. And here are our collaborations listed, again, St. Joe's Hospital, the Corrections, Police Department, and Fire. So if you have any other questions pertaining to our services, our contact information is listed above. Linda Bryan, who is our program manager, Hillu Beyene, who is our peer recovery, and the 41088 reach line, which is 410-887-3224. And I thank you so much. Have a wonderful day.
Just like to mention one of the benefits we talk about.
Sure. Are we doing questions at this point?
Yeah, I mean, I think at this
Yeah.
point.
Yeah.
Yeah. Oh, I'm sorry.
Program so far.
Yeah.
Just how do we access?
Well,
Sure.
we kind of broke down, we're breaking the line.
Yeah.
So we know we have a need. We know we have a program that can address that need. And how can we use it? How do we use it? The program exists. It's alive right now.
Right.
If you get a call later on tonight, since this class is completed, you can use this resource.
Okay. So to answer how EMS can engage peer recovery support services, it's just a streamlined process. So our 410-88 reach line is listed as a dispatch process. So you will call EMS, any EMS provider can call into that line, answer the call from the peer. We have had several incidents where EMS was actually on the scene to any substance use related concern, particularly overdose. We have been called out several times, and when we're called out, we'll either meet you there on scene, or we'll ask you which hospital that you're actually transporting to, where we can actually engage the person there. There's been several times at the residence that where we were there, either we were there when the medic was there, or we actually waited. It was a medic one time that asked us to transport a person to treatment because they would not go. They would refuse the service, and or a person who was on scene from an active overdose complained that they were sleepy, did not have an overdose. We trained the family members and we trained the actual person in question. A person who was discharged from the hospital and trained at her residence. When she got home, we were actually standing outside. There is no conflict of interest. I know that that's asked a lot about ethical concerns and confidentiality. We are all employed by the county, so that means we can share our information without incident. Our recent ride along that we did actually involved another peer, and with that, the person was ingesting substances through her feeding tube, and at that time we engaged at that point. She was actively using services, so the medic was called. She was transported to the hospital, engaged with the peer at that particular hospital. From that time, we engaged her at the hospital with a confidentiality form created from the hospital and us. And then we were able to visit her from that point, after which on discharge, she was given outpatient treatment and consistently engaged by the peer. So there is a continuum of care being offered by us with peer support services. One thing that was mentioned about what we are and what we do, because I heard a lot of chatter about what is peer services, right? So the best perspective that we can give is a non-punitive approach to connections to and linkages to treatment and wraparound services, the best possible way to do that. And it's been a great collaboration with Baltimore County Fire Department, along with the police department, and in community members who actually call into that line and receive help.
Like they mentioned, right now the line is 8:30 to midnight, Monday through Saturday evening. There is a voice recording between midnight and 8:30. Information, and I can attest that they do follow up first thing in the morning to try to keep citizens connected with the process, and there has been some talk of maybe even expanding this program to 24 hours for us. Yes?
Is it, if we call from dispatch, do they have us, we're out there and somebody forgot the car, does dispatch have all that?
They do. Our experience is calling directly is the best, most efficient link. We're 88 reach. That's the number we call, and that's the number of citizen calls. That's a great question, but it's also the number I'm calling from the scene. We've experienced the program's kind of growing, and it's only limited a little bit by creativity and ingenuity, but we've used it in a lot of different circumstances. But a couple situations that have been very successful is you respond, and maybe we resuscitate someone and they want to refuse service, but we want to create linkage. We respond, we resuscitate somebody, and they haven't admitted to substance use. They're just real tired. We've given this handout to someone who was real tired, and they made a call 3 days later, and when they showed up at their front door, they had this paper in their hand. So everybody's got somebody who's been affected, so even when we meet citizens who we suspect could use the resources, but aren't maybe fully engaged or willing to engage at that moment, we'll still provide this lifeline to them so that they can reach out when they're ready. I think everybody's recovery, everybody's addiction is different. It's been fascinating to watch them assess someone on the scene as to where they are in their addiction and where they are in being willing to accept treatment and head to recovery. And they're very dynamic and fluid in how they respond to that citizen, and there's a variety of options, and they follow up with them. So there's linkage, there's a tether. Once folks are in the system, there's a continual reach out to these folks to make sure they're doing okay, and when they're ready to accept treatment, if it's not right then, they're in a position to place them in treatment even down the road. So we're not. It looks like there's an ability not to lose folks as much. Kind of like us, we'll resuscitate and they refuse and they leave the scene potentially. I mean, this creates some linkage there. It is voluntary on their part, but most of my personal experience is looking in someone's eyes and kind of explaining the program and the resources. They want help of some type. And we'll make the call at 88-REACH. Someone answers the phone, a peer recovery specialist, and they know who we are, what we do, where we're at on scenes, and we can provide linkage. If it's between hours, these folks can meet us on the scene. They mentioned St. Joseph Hospital. That's a health department funded position, but every hospital has a peer recovery specialist. So again, kind of going back to that clinical situation I mentioned earlier, where clinically a physician may look at you when there was a safe time, you might be discharged without a whole lot of intervention in between. Now there's a person at the hospital that kind of picks up the services they offer to that citizen, and not only as part of their clinical observation and treatment, but when they get discharged from the hospital, there's a plan hopefully to get them towards rehabilitation services. And then these folks link with those hospital peers to kind of track and follow people in the community that might need help. So we've used them on the scene many times. They're usually there, my experience is within 15 minutes or so. And it's been pretty fascinating for me personally just to watch them relate to citizens in a way that we can't. They have a different experience and a different understanding of the disease process, that they reach folks in a way that's very compelling and I think very effective. And they'll put them in their car and take them to a rehabilitation. They'll link and set that up, have family members kind of recruited to help make that hopefully a successful transition. It looks like it works. Like I said, resuscitate and pat them on the back, wish you well, that always left me frustrated that did we make a difference? And this one provides us with that real-time linkage. Like I said, that next call tonight, if you're on an overdose, and it doesn't have to be, we've kind of focused to talk a little bit about opioids. It can be alcoholism. We've had some of those, frequent calls by individuals where we'll see them over and over again, and maybe they're in an alcohol disease process. They can help with those folks as well. We had one case that we worked on where a young lady was huffing that cleaner they use for computers. And we brought Tiffinee in on that case, and she was very helpful. And that particular patient would only go to the hospital if Tiffinee rode in the back with her. And Tiffinee got in the back of the ambulance and went to the hospital. And that was just an example of us all working together to try to recruit that citizen to go seek medical attention. And without Tiffinee that day, this young lady probably would not have gone to the hospital. So we personally seen success, and that's kind of we're excited to come out here and share this because it's live, it's available to you, and it's an incredible resource. And I think you'll see a little bit more information. I was explaining to Dr. Barinholtz, from our leadership, where this is the program that we're going to use right now on scenes to try to link our citizens with kind of definitive resources to hopefully get into rehabilitation and kind of get back to their loved ones and their productive lives. I'm sorry.
Yeah, so this is something it seems like every week at least, So I see how this is crossing like HIPAA a lot. So if I, have an overdose patient, we bring them back, like you said, don't just pat them on the back and send them on their way. Because they're able to refuse, or they're in police custody because they got into an accident, or they do want to go to the hospital with us. Do they have to consent for us to call this hotline?
No.
I'm going to be giving information.
Yeah,
you guys come out to their house, but
Right.
If they don't want you or they don't want the help, I'm giving information that's personal to them and they don't want me to.
And Tiffinee touched on that, and
So I think it's just initial engagement, right? So there's been several incidents where we have either just placed the medic has even just placed the pamphlet in their pocket, or if the person is there and you feel like that's a great candidate for our service, right? You can simply just pass the card along, create the conversation. You actually can be there and make that call on speaker. The person is present and in your care, and ask that conversation, because if they say yes, like this is something that I would like to get them engaged in, they want the help, we can come out. Or they'll say, no, I'm fine, and you still can just place the card in their pocket. That's not crossing any HIPAA concerns. We're all employed by the same government agency. We are all employed by Baltimore County government. So that we had that conversation. We have had it several times, so you're not crossing anything. And normally when the medic calls in, you call in, I'm medic, I'm on medic 17, I'm here at whatever the address is. I have a young man who's ingesting alcohol, says, but we have picked him up several times. I'll say, okay, where are you? And you tell me where you are again. I write down your name, and I also get your contact information, because I want to keep in contact you while you're traveling. If you say, okay, I'm headed to GBMC, then I want to come to GBMC. When I get to GBMC, we already know there's a peer there that's going to engage them as well. So we're trying to create the conversation before they get there. That way, when I called University of Maryland Midtown campus today and told them that's a person that will be coming in and he needs treatment, they're waiting for them. So it's just creating that bridge and linkage. You don't necessarily have to give us names. Okay, you're medic 3 and you're headed 2, and when I get there, I'll say I'm here for medic 3, right? So then the charge nurse usually creates that conversation if you're at the hospital, because we know that person went into room 3, right? And then they'll create that conversation. If they say yes, then we can come in and see them. We have crossed that with several hospitals, especially the ones that we're working with now, which is St. Joe's, about HIPAA. And our charge nurses and our social workers have been our greatest help with getting access. So you're not in any ethical violations as far as just calling us. And what's more important is that family member that called, whether it has to do with substance use, especially with an overdose, because the family member called, someone had to call for you to come out, and it couldn't be the person that's overdosed, right? So when we get there, we literally take the kit out of our pocket. Can I have it?
Yeah. We have kits.
So we have kits. We train that family member that's there with this kit. And the hope is that you're putting the card in their pocket, we're training the family on with the kit, and that we won't revisit this process. And then I'm following up by calling you, letting you know. Even if you left, I'm going to let you know that I've been there.
Yeah,
What?
The HIPAA question is an excellent question. I can speak operationally. This is considered as part of the healthcare continuum. Right, getting back to the HIPAA question, that's come up, and that was a concern initially. How much information can we share? Because they're health department employees, this is considered the continuum of healthcare. They're part of the healthcare team for that individual, and they're professionals. So we're able to share information, with the peer recovery specialists when we're dealing with that citizen in terms of their overdose or their substance abuse disease process. They're also very good. I've seen interactions with families, and they're very professional in how they engage the family, and so privacy and those things are respected, but we're able to still accomplish very successful results. And I think Tiffinee may have alluded to this, but part of the feedback loop that she's recognized, and I certainly completely endorse his feedback to you as a provider. So if you had a referral and had a citizen that you referred through the 88 reach line, that they'll provide you with a phone call back and let you know how that encounter went and what happened with that individual. And that's kind of like that feedback that just secures optimism in the program when they tell you, hey, we were able to place a citizen in treatment and on the road to recovery, so to speak. So that's going to be part of this too. There's some interesting things we're looking at in terms of hotspot maps, giving them information on overdoses we ran in the county, and provide some information so that we make sure that we can link them up with hopefully every citizen that has a substance abuse issue. And it'd be interesting to see. They're also measuring the program, so at some point I think we'll be able to look at not only use, but we'll be able to measure and look at how successful the program is. But like I said, I can't overemphasize that linkage that we now have that we just didn't have before. And it's as a provider, it's very encouraging, and I think it's a very important program. Yes, Dr. Barrow.
Some counties are participating in Narcan lead-back programs. Can you tell me anything about discussions with the Baltimore County?
This, in effect, is our Narcan lead-back program, but I think it takes it up a notch, because not only are we leaving Narcan, but we're also opening up all the resources that are available to the group, to that family and citizens. And this isn't just, the circle was the patient, resuscitation, then the patient, rehabilitation, but there's family members, there's many people involved in an addiction or a substance abuse disease process. And that's where the reach of allowing family members to become part of it, because there's also help and counseling for them. Many family members say, like, I have a young adult or a husband, a spouse, whoever that's important in their lives has this problem and I don't know what to do. So there's a lot of counseling that goes into the families as well. So it's really a 360 on how we address this issue in the community. And I'll let Hillu speak a little bit more about the Narcan leave back, but they carry the kits, and that's part of their engagement in the community.
Yes, thank you. Yeah, I wanted to talk about a couple of the things. You asked about the HIPAA. One of the things we get on a weekly basis is overdose survivals from the police departments and such. And what we do is we call these people up and said, we know in the last 3 months you've had 2, and we approach it. We have the language to talk to them, say, I'm not a counselor, I'm not a therapist, I'm a peer recovery support specialist. Do you know what that means? And then we identify and kind of relate and say that you've had this, how can we help you with your recovery process? Is this something that you're interested in? Would you like to talk? More at a time, we get no answers, but we also have the backup information. If we don't reach them, we got the person who called. So we haven't had any adverse. We either reach them and have a conversation and be able to move them on. Out of those calls we've had several that have chosen to go into treatment. We have more that haven't responded, but we've had some that decided to go, well, I'm not quite ready to quit, but maybe I'll try medication assisted. So we've been able to link them to that. So different things of, planting the seeds and such. So we're able to do that. I've had EMS folks, call and say, you know what, I just left St. Joe's. There's somebody maybe you should go check out over there, and we go find out who they're there and such. Now the Leave Back program is the fact that we have, we actually can leave back. We all carry Narcan with the kit. It has all the kit, including the Good Samaritan law, which lets people know if somebody uses in front of you and they overdose, don't leave. You can call the police and provide help until EMS gets there, and you won't get prosecuted for it. So this program, it allows us to leave. We don't need any citation or anything to leave it behind. We're trained to give them a quick 10 to 15 minute training. We have the documents in here. We just open it up and give them at the street. That was with the captain, with Lieutenant Marvel. We were riding along We coming back from a call. We look over and she looks at me, and there's this young lady, really distraught, hot, tired, just walking on the side of the street. And I said, she looked like she needs help. And Lieutenant Marvel said, is this why you mean meet them where they are? You know, literally, you know. And we said, yes. So she kind of pulled over and allowed me to go out and engage and say that, you know, how can I help you? I'm not threatening. We're coming away. You know, you can look at each other, understand some of that stuff. And was able to sit down. She says, I'm thirsty. And that's what we do as Reach. We carry water. I didn't have water. I ran across Wawa, got her some water. You want to sit down and talk. Found out 2 days earlier her son had OD'd, and she was on her way over to her daughter's house a couple of blocks away. She didn't want anything. She just wanted to rest. She was still mourning. She had used it. I said, do you have Narcan? She says, I used it. I don't have any more. Well, I had it. So I sat there, gave her a quick training, put Narcan in her bag. She didn't want anything else, but that was all I can do, give her the Reach number. That same day when we were riding, got a call bench over at Giant. And Lieutenant Marvel says, that sounds like so-and-so. You know, you were mentioning about somebody you always see, you know, you always know, you know the area, it sounds like that call. And we go out, and it was a gentleman that laid out, you know, he was passed out from alcohol and just was not responsive to, you know, to wake up and such. So EMS came, an ambulance came, what's getting on? And she said, let's put it in his pocket. So we folded up all the documents and just put it in his pocket, you know, and things of that sort. So the Leave Back program allows us to leave for the families and such. We're doing pop-up trainings now. Just the other day, we ended up outside of an NA meeting, set up a tent, and just decided to do a Narcan training. Guess what? 18 people that came out of there did the Narcan training real quick and went home with a kit. So we're able to provide and leave this as you do the essential. And one of the key things I want to mention is that we recognize the work you all do, life-saving. In the city of Oakland, I am a beneficiary of your profession from years ago in the city of Oakland. So what you do is timed and is clocked. We see it. We don't get in the way. We watch you. We want you to do your work and such. And what we've learned being in your house is that we want you to know that we respect and want to see you do that. But we will jump in, or if you're with them, we'll be with the family doing a Narcan training, you know, and do that. So we do this with the passion that somebody took the time to do this for us. And now with what you have done, we just want to be able to support that.
Yeah. Again, these cards were made up initially. We realized we have to get this out to folks. And these were just delivered tonight, and it looks like this is going to be the card that you'll probably see on your units. And we'll make arrangements tonight to kind of get them in our hands, and then we'll distribute them. So you have them like your senior program cards, you know, where you have your metric of what resources to utilize depending on the situation you have. This will just be another tool in the toolbox where when you have that overdose or that substance abuse or that family that's in crisis, you'll be able to call the number on the scene, talk to a peer recovery specialist. They're good about asking you for information they need, what they have, and depending on the time, they'll have a peer recovery specialist engage there at the scene with you, or potentially meet or follow up through the hospital system. So it's something you'll see hopefully in the very near future. You can all take some tonight with you, obviously, but you'll be seeing these on units. And yeah, it's just important that everybody knows that this is a living, breathing document. Use it. It's a great resource, and you know, we think it's it certainly sets us up to, you know, making our communities you know, much safer and better places for all our citizens. Any other questions?
Thanks, you guys. That's great. And thank you for the important work you guys do. You look at it that way.
Thank you.
Yeah.
Thank you, Paul.